Hello everyone. To start with the respiratory portion of the Amedex 2022, there is first MCQ, which is all about a 30-year-old woman recently migrated from China to Australia, and she's undergoing a health assessment. Before coming to Australia, she has been working in the cotton mill for 18 months. So whenever there is a respiratory problem in the form of shortness of breath or chest tightness or the cough, and there is a history of occupation, then the MCQ is leading to you towards the occupational lung diseases. So, one of the most important occupational lung diseases are byssinosis, berylliosis, silicosis, and the occupational asthma. So, here the clue for the MCQ solving is the cotton mill. Cotton is directly for the byssinosis. So, before just going other statements of the MCQ, we have just made the diagnosis of byssinosis straightforward. Next important thing is that whenever there is a byssinosis, there is a temporal relationship to the workplace and the symptoms of the patient. Like in this MCQ, it is mentioned that whenever the patient is off the work or the symptom is throughout the weekend, this is basically showing the temporal relationship. So this is a clear cut MCQ about the byssinosis. One hint is your acute respiratory symptoms, which is occurring throughout the week, and there is ease of symptoms through the weekend, and there is exposure to the cotton. So answer here is your byssinosis. Now we talk about the byssinosis. The clinical picture given the scenario is highly suggestive of byssinosis as the most likely occupational lung disease, and there is almost exclusively work in the workers who are in contact with the unprocessed raw cotton, especially those who are exposed to the open bales of the cotton and work in the cotton spinning and the carding rooms. Often byssinosis occur in workers in at least 10 years of exposure, but it can also develop acutely in a matter of hours or days. So if we divide the disease, there are basically two categories. One is the chronic and one is the acute. Chronic is in the form of 10 years or many years take to develop, and acute within the hours and days. The etiology basically behind the cotton work or the cotton dust is that there is an endotoxin present which causes the chronic bronchitis and the gradual decrease in the pulmonary function. Other important diseases which is just like similar to the byssinosis is the occupational asthma, but there is no temporal relationship with the as in the case of byssinosis in the temporal asthma. The symptoms basically start if we find the chest tightness or the shortness of breath. It can be anxiety, it can be asthma, it can be occupational dust disease like byssinosis, but again the temporal relationship is the clear-cut clue. The disease is basically restrictive lung pattern. Whenever there is restrictive lung pattern, there is decreased FVC and decreased DLCO, which is also an important clue to diagnose the condition. Another important lung disease, which is occupational lung disease, is beryllium exposure. But the beryllium has different exposure, not as the cotton meal, but it is used in the aerosol computer electric devices. So if in the scenario these things are mentioned, this is a clear-cut indication of berylliosis. Silicosis is due to silica dust, and it presents as acute silicosis in the less than 3-year exposure, accelerated silicosis in the 3 to 10 years of exposure, with the higher disease progression to chronic silicosis. And chronic silicosis over 10 years, it is basically involves your upper lobes of your lung. So these are the different occupational lung diseases which are very important. Next MCQ comes: which of the following options is the most appropriate test to differentiate pulmonary tuberculosis from the sarcoidosis? When talking about the pulmonary symptom, chest x-ray or the sputum examination is very much important to diagnose any respiratory condition, but they're non-specific marker. Likewise, the ESR and CRP, these are the non-specific markers of inflammation. The only things which could gives us clear-cut clue about the TB is basically your Montauk's test or tuberculin skin test. It's not positive in sarcoidosis, so only differentiating test is Montauk's test. Sarcoidosis and pulmonary TB can have similarities in presentation. They both present associated with the vague systemic symptoms of fever, night sweats, and weight loss, which are the B symptoms or the night symptoms or the cough, and they are similar on X-ray. So differentiating is just the X-ray finding can be or the biopsy finding. Both condition are granulomatous diseases. TB has the caseating granuloma, while the sarcoidosis is non-caseating granuloma. This is a difference in the biopsy, but in options biopsy was not mentioned. Other tests are very non-specific. Next comes 35-year-old woman presents to emergency department with a sudden onset shortness of breath and the right-sided pleuritic chest pain. On examination, she has the blood pressure of 130/89, pulse is 102, so the patient is having the tachycardia, and respiratory rate is 25 breaths per minute. Neck and forehead veins are flat, and the trachea is slightly deviated to the right side. When trachea is deviated, there is some lung pathology. When you auscultate the lung, there is a hyper resonance to percussion on that side, which is clearly showing the pneumothorax. And there is no other abnormality on the chest x-ray. Which of the following is most appropriate next step in management? Whenever you are managing the patient with the pneumothorax, first you have to make the diagnosis very clear whether it's primary pneumothorax or the secondary pneumothorax. But before primary and secondary, you have to make it very clear whether it's traumatic or spontaneous pneumothorax, because the management of all the pneumothorax are different. First of all, make this a very clear concept that pneumothorax can be primary and secondary. If the primary pneumothorax is small, it's less than 15% of the lung surface area is involved, then you can observe the patient. But if the primary pneumothorax is large, greater than 15%, or the patient is symptomatic, you need needle insertion or the needle aspiration. So in this scenario, the patient did not has any history of trauma, so the pneumothorax is basically primary. It's not secondary to any trauma or the injury. So primary pneumothorax, and the size of the pneumothorax is 15%, which is clearly greater than 15%. So it's basically greater than 15% and it is symptomatic. So we need this needle aspirations. If it is less than 15%, then we can observe as well. If the patient is having secondary pneumothorax is basically due to trauma, or if it is greater than 15%, then you have to insert the chest tube. Here, needle insertion is not the option. Here, the chest tube insertion is the option. So this is the important thing for whenever you are dealing with patient of pneumothorax. Primary pneumothorax occur if the following criteria are met. There is no respiratory finding on examination except those related to pneumothorax. There is no history of lung disease. There is no chest x-ray finding. The patient is less than 50 years of age. There is no history of smoking, because there is no risk factor to the patient, and patient is having no clinical and lab findings, then is said to have the primary pneumothorax. But if the patient is having underlying respiratory problem like COPD, or patient is having chest x-ray abnormality, and the patient is age is greater than 50 and he's smoker, then it's clear cut secondary pneumothorax. So management is all about different in primary and secondary pneumothorax. Primary pneumothorax is most common in the thin tall male 20 to 40 years of age. Spontaneous pneumothorax is older than 50 years of age. Next MCQ comes about which of the following is the most common finding in the patient with a pleural effusion? In the patient with pleural effusion, all findings are non-specific. The most important finding is dyspnea, shortness of breath. Dyspnea is the most common and prominent clinical finding in the pleural effusion. Cough can be present in patients with a pleural effusion, and it is often mild and non-productive. Cough is basically a non-specific symptom. It is present in many of the respiratory problems. More severe and bloody purulent cough is indicative of pneumonia and endobronchial lesion. Chest tightness is not a feature of pleural effusion. Pleural effusion does not present with a weight loss. It's a feature of TB or lymphoma. Pleuritic chest pain is a feature of infarction or mesothelioma. So the only option left behind is dyspnea. So dyspnea is the right answer for the pleural effusion. Next is a very important MCQ and very important topic, which is asthma. 12-year-old boy is brought to the emergency department by the mother with a complaint of cough and wheezing. Cough and wheezing are clear-cut symptom of asthma. She had previous episodes in the past and has not any specific treatment so far. On examination, she has a respiratory rate of 40 breaths per minute and the temperature of 37.5. And on chest auscultation, widespread wheeze is noted bilaterally. Rest of examination is inconclusive. Which of the following is the most likely to make a diagnosis now and in emergency setting? For the patient of asthma, the response to bronchodilator therapy is very much specific for the diagnosis and the treatment of the patient in emergency setting. So improvement with salbutamol is an important clue, and it is important treatment in the form of asthma. The scenario is typical for the exacerbation of previously undiagnosed asthma. It is more common cough and wheezing in the children. By definition, asthma is a reversible airway response to bronchiality. Reversible is very important in the case of asthma and triggered by the many factors like you can have allergens, cold, exercise, stress. nauseous inhalants, dust mite, etc., reversibility and symptom relief after administration of bronchodilator. It is a key issue in the diagnosis of asthma. Other images modality like chest X-ray or CT scan is not routinely used for the diagnosis of asthma. It's basically a clinical diagnosis, and spirometry can help in diagnosis, but it's not an emergency procedure to do. Methacholine talent test is another option which can be done because it shows a reversibility of the bronchodilator response in the patient of asthma. Pulmonary function test is a valuable tool for monitoring in response to treatment. Inhaled salbutamol increasing values read by the pulmonary expiratory flow rate indicates appropriate response to the treatment, but it's not an emergency diagnostic test for asthma. Next comes a 6-year-old boy is brought to your attention because of the frequent episodes of the wheezing and cough at night and during the exercise. You prescribed a salbutamol on a need basis and regular low dose inhaled flucortisone. Which of the following medication is most effective in preventing the episode? Patient is having the SABA, which is a short acting beta 2 agonist already, and he has in the night symptoms. So what is the most important preventive medicine? Preventive medicine is basically your fluticasone. Fluticasone is in the form of steroid, or a patient. First of all, you have to understand the concept of asthma. The child is having persistent asthma. What is the persistent asthma? First of all, there are different definitions of the categories of asthma. One is the intermittent, one is the mild persistent, moderate persistent, and severe persistent. Intermittent is when the patient is having symptoms more than 1 week apart. Like 1 week is symptom free, and the patient is having 1 week apart symptom, and the night symptom occurred less than 2 times per month. Like 2 per month is the night symptom, and 1 week apart is patient is having symptom. This is called intermittent. Mild is when the patient is having more than once a week but not on the daily basis, and 2 times per month night symptom. This is mild persistent. Moderate patient is having daily basis symptoms and the night once in a week. And the persistent, severe persistent, same, like daily basis patient is having symptoms in a day and frequent night symptoms, like not once in a week, more than once a week. Then this is severe persistent asthma. For the persistent asthma, the treatment of choice is the regular use of inhaled corticosteroids and the short-acting beta-2 agonist as needed basis. Patient is already taking SABA, so another option you can add is ICS, which is inhaled corticosteroid in the form of fluticasone or beclomethasone or budesonide or cyclisonide. So these are the different options which can be added. LABA is not a preventive medication. SABA is the treatment of choice for intermittent asthma. Chromoglycate can be used for the patient who are not responsive to the ICF and require more complex regimens. And although not as effective as ICS, 2-week trial of montelukast can be considered first in an attempt to spare the child for the ICS. So this is also an option. This is not first line option. So most important preventive treatment was ICS, which is inhaled corticosteroids. Next comes a 40-year-old woman presents to the emergency department with a sudden onset chest pain, dyspnea, and fever of 39 degrees centigrade. She has arrived from Canada to Sydney 2 days back. Which of the following would be the most appropriate next step? This is very, very important and very interesting MCQ to understand. This is the MCQ all about the patient is having a pulmonary embolism. Whenever in the MCQ there is a clear sudden onset of the chest pain or sudden onset of dyspnea, this is giving a clue to the pulmonary embolism. When the patient was immobilized and patient was having post-operative procedure or duration, or patient having bed rest. So this is an important clue for pulmonary embolism. Before jumping to the investigation of pulmonary embolism, which are gold standard or diagnostic investigation, is CTPA and VQ scan. The important thing is to rule out the underlying pathology, and the basic step is chest X-ray. So next step, patient is not undergone any investigation, so you have to do the X-ray first. And if the option patient is already have undergone chest X-ray, next option would be most appropriate ECG, but it's not mentioned in the option. So we will go for the chest X-ray. Justification is travel, especially by the air, longer than 3 hours. It is a risk factor for the development of thromboembolism in the form of DVT or pulmonary embolism. Sudden onset of dyspnea is the most important presenting symptom in the pulmonary embolism. Pleuritic chest pain, cough, hemoptysis, hypoxia, even collapse, hemodynamic instability can be present as well. Fever is common, but it can be a possible symptom. Initial investigation is chest X-ray. ABG is performed initial investigation. Typical finding of pulmonary embolism is hypoxia and hypocapnia. CTPA VQ scan are definitive diagnostic tests, but these are not initial steps. D dimers can be used for the pulmonary embolism if is it likely for the patient who are having low probability of pulmonary embolism to exclude the pulmonary embolism. Next comes 26-year-old woman presents to the emergency department with a shortness of breath and a pleuritic chest pain. Based on the history and clinical findings, she is fine, suspected to have the pulmonary embolism. So he has given the your diagnosis pulmonary embolism. She has a family history of thrombophilia. Which of the following is investigation of choice? We already have discussed that for pulmonary embolism, the investigation of choice or the definitive diagnosis is made on the CTPA and VQ scan. But the important clue or catch point in this MCQ is the age of patient, and she is female. CTPA, which is angiogram, computed tomographic pulmonary angiogram, is associated with very high dose of radiations, which are not good for the reproductive age females. These are basically teratogenic. So, whenever in MCQ of pulmonary embolism there is a female with less than 50 years of age, you always go for the VQ scan. You don't go for the CTPA. Otherwise, the gold standard is CTPA. So the answer is VQ scan, computed tomographic pulmonary angiogram, and VQ scan are currently imaging modalities for the definitive diagnosis of pulmonary embolism. CTP is preferred over the VQ scan because it is often readily available, easy to use, and more convenient to the patient. So these are the three benefits of CTPA. It is readily available, it is easy to use, and more convenient to the patient. Unlike VQ scan, underlying lung disease evident on chest X-ray does not affect the specificity of the test. Besides, it can detect smaller and more distal emboli in the pulmonary arterial tree as well as other conditions. Drawbacks to this method is more radiation exposure and detection of clinically insignificant emboli that trigger unnecessary anticoagulant. CTPA is always the method of choice except is very important, except in the following condition: women of reproductive age less than 55 years, those who have poor GFR, because we are using contrast in this procedure. So if the patient is having renal function decline, so we can't do the patient can't go for the CTPA. Or if the patient is allergic to the contrast media, or patient is already pregnant women. This woman is less than 55 years, so CTPA is not an option here, so we are going for the VQ scan. Chest X-ray is performed in all patients suspected, like in previous MCQ, in all patients with a suspected pulmonary embolism to exclude the other possible causes and guide to selection of the imaging modality. So if the answer is about the initial management, if the patient is not undergoing any initial investigation yet, then the option will be chest X-ray. After chest X-ray, the option will be ECG. But if he is asking about the definitive diagnosis or the more important or gold standard diagnosis, then it is CTPA. But before selecting the CTPA, you have to see the contraindication of CTPA, which is the age of patient, renal failure or reproductive age, pregnancy, or the patient with the allergic to contrast media. In these cases, the option is the VQ scan. So this is a very important and very simple MCQ about the pulmonary embolism. Next comes: a 62-year-old man presents to the emergency department with a sudden onset chest pain and shortness of breath. Again, there is a sudden onset chest pain and shortness of breath. He has a chronic kidney disease. An important clue: he has chronic kidney disease. Documented reduced GFR of 25 ml per minute on examination. Blood pressure is 110/75, pulses 112. ECG is performed, that is normal. Chest X-ray, so initial investigation, which is ECG and chest X-ray, it's already being done. X-ray show wedge shape opacity in the periphery of the right lung. Which of the following would be next investigation in this patient? So it's a clear-cut scenario of the pulmonary embolism, which is showing wedge shape opacity on the chest X-ray. This is very specific for the pulmonary embolism. Patient is having sudden shortness of breath. Symptomatically, patient is having pulmonary embolism, but the patient is of chronic kidney disease. Best investigation is definitely CTPA, but here in this MCQ we will choose VQ scan because patient cannot undergo CTPA due to declining renal function. Sudden onset of dyspnea, shortness of breath can have a variety of etiologies. Spontaneous pneumothorax, pulmonary embolism are the typical example. Pneumonia and other respiratory problem. Possible explanations as in cardiac ischemia. In approach to this patient, ECG and chest X-ray are the initial step. As we have already discussed that the initial step is ECG and chest X-ray. It narrowed down the possibilities, and ABG is indicated as well in the presence of hypoxia. There is no comment about the presence of fever in this question. Infectious causes can be a weaker possibilities. ECG is normal, excludes the cardiac arrhythmia as a cause. Wedge shape opacity on the chest X-ray suggestive of pulmonary infarction, making the pulmonary embolism likely diagnosis. So it was an important clue to understand Definitive diagnosis of pulmonary embolism relies on imaging study, CTP or VQ scan. However, not everyone will sign and symptom of pulmonary embolism should go the diagnostic investigations. First, we apply the Wells criteria. Wells criteria is about the ongoing anticoagulant treatment or contraindication to CT, pregnancy, suspected massive pulmonary embolism with shock or estimated life expectancy less than 3 months. Generally, CTP is preferred option over VQ, but readily available, easy to use, and more convenient. These were the three benefits of CTPA. But CTPA cannot be performed in women less than 55 years of age or the poor GFR less than 40, and those who are allergic to contrast media. So this patient has poor GFR, so we are choosing the VQ scan. Next MCQ is about 20-year-old man is admitted after the motor vehicle crash in which he sustained a multiple lower limb fracture. He underwent surgical fixation of his fracture 5 days after the surgery. So there is a window period of 5 days. He was immobilized for 5 days and he is having the multiple rib fracture of the motor traffic accident. He becomes pale, clammy, and short of breath. But BP is 110/70 and the pulse is 100. Which of the following investigation is most likely his current diagnosis? So again, there is a clear-cut clue for the patient is having pulmonary embolism, but the patient has not undergone any initial investigation in the form of chest X-ray or ECG. But here the important thing is most likely diagnose his current problem. This is not asking about the initial investigation. If here the question is initial investigation, definitely our answer would be chest X-ray. But for definitive diagnosis, patient is having pulmonary embolism. For pulmonary embolism, definitive diagnosis is made on the CTPA or VQ scan. This is not a female patient of reproductive age, so we are very much confident to choose the CTPA in this question. Orthopedic surgery, immobilization, bed rest more than 3 days, strong risk factor for the venous thromboembolism in the form of pulmonary embolism. Again, the same MCQ we have already gone through, that CTPA is avoided in women of reproductive age and those with a GFR less than 40 and those who are allergic to contrast media. Here, there is no contraindication like these 3 points, so CTPA is the right answer here. Next comes a 42-year-old woman sustained a motor vehicle accident, had femoral neck fracture, and the 5 days after the surgery on fracture, she developed sudden onset chest pain and dyspnea. This is a more or less same MCQ. She developed sudden onset chest pain and dyspnea, which is indicative of the pulmonary embolism because she is having 5 days of rest after surgery and having the motor vehicle accident. She's on oral contraceptive pills. On examination, she is afebrile, heart rate is 100, BP is 110/70, respiratory rate is 24, lungs are clear on auscultation, chest X-ray and ECG with for the initial investigation already done. Which of the following is the most appropriate next step in the management? Next step is to establish the diagnosis. Definitely, we are going to the investigation of pulmonary embolism. Again, here the patient is female and she is of less than 55 years of age, so we will choose VQ scan here. Again, the justification is same, that the patient is having less than 55 years of age, so we are selecting the VQ scan. But the important thing here, additional thing rather I will say, is a Wells score. This is very important. Simplified Wells score, the points are very important to learn. There are different points about the simplified Wells score. Clinical sign and symptom of DVT, like if the patient is having leg swelling or the pain elicited among the palpation of right leg, the point is 1. Then if no alternative diagnosis more than pulmonary embolism, again it's 1 point. Patient is having tachycardia, it's 1 point. Immobilization for at least 3 days or surgery in previous 4 weeks, it's 1 point. Previous DVT, pulmonary embolism, hemoptysis or malignancy, it's giving the 1 point. If we combine this, patient is having Wells score if the points are greater than 2. The interpretation of this Wells score is that if the patient is having score of 2 or higher, it's likely to have pulmonary embolism and should undergo imaging, either CTPA or VQ scan, depending upon the patient's age and other risk factors or contraindication. If the patient is having 0 or 1, it's unlikely to have pulmonary embolism. Here in this group who are unlikely to have pulmonary embolism, D-dimer assay is used to safely exclude the pulmonary embolism. So it's an important score to remember. Next come an inpatient 65-year-old man comes with acute chest pain and dyspnea 7 days after hemicolectomy. 7 days is a window period. It's definitely greater than 3 days, which are according to the well score, and there is a hemicolectomy post-operative. On examination, BP is 140 by 95, heart rate is 106, which is tachycardia, and respiratory rate is 22 beats per minute, breaths per minute. Which of the following is the most appropriate next step in the management of this patient? So he is asking about the next step. Next step is definitely patient has not undergone any investigation yet, so we will go for the chest x-ray in this patient, definitely. But in this patient, another important clue in this patient is symptomatology. The patient is coming with the acute onset chest pain, not like clear cut cough or shortness of breath or anything else. So for acute onset chest pain, we have to rule out cardiac disease as well. So that was a little bit tricky MCQ. Like we choose the chest X-ray, but it was ECG due to the symptomatology of the patient. Because sudden onset dyspnea with or without other sign and symptom of pulmonary embolism such as pleuritic chest pain, tachycardia, persistent hypotension, cough is the background of recent surgery, should raise the suspicion of pulmonary embolism. In general, individual clinical enzyme do not allow the exclusion or confirmation of pulmonary embolism. History of recent surgery increases the possibility of diagnosis. But performing ECG is mandatory to exclude the cardiac ischemia, both as a cause of chest pain or concomitant even as a result of hypoxia and cardiac ischemia triggered by the suspected pulmonary embolism. So it was a tricky MCQ, that was the ECG due to rule out the cardiac ischemia. On ECG, you will find tall P wave in the lead P2, which is P pulmonal, right axis deviation, and S1Q3D3 pattern. Next will be chest X-ray. Comes next, not only to exclude the other lung condition, but also to rule out the imaging modality. And CTP and VQ scan is definitely the most appropriate investigation to rule out the pulmonary embolism. So this is all about the respiratory portion. This is not